Presentation from Married. And we have Lynn Swinburne with us today. She's a Senior Health Promotion Officer with CervicalCheck. And we have a presentation also from Mairead O'Connor. So, okay, Lynn?
Hi everyone, my name's Mairead O'Connor and I'm a Research Officer with the Performance Evaluation Unit at the National Screening Service. And together with Lynn Swinburne, we're going to present the webinar on increasing participation in cervical cancer screening. And just by way of background, prior to my role here as Research Officer, I was a researcher with the Survivor group, which investigates cervical cancer screening participation, HPV infection among women in Ireland. So I'll talk a little bit about one of the studies that I was involved in on cervical cancer screening participation. So the learning outcomes for today are to understand the barriers to cervical screening, to review what communities or what women may be underscreened or never have been screened, to review what works in an increasing screening participation from a primary healthcare perspective, and to showcase new accessible information available from CervicalCheck. So what does the evidence say internationally and nationally? So this study was a study conducted among women in Ireland, and we know that cervical screening coverage is consistently lower among older women in Ireland, so women that are aged 50 plus than younger women. And we conducted a study in 2019 with CervicalCheck as part of the Survivor research group on cervical screening participation in order to understand the possible reasons why older women are less likely to go for screening. So what we did was we interviewed 48 women over the telephone about their views and experiences of screening. And these women had various screening histories. So some were under-screened, some had never been screened, and some were regular attenders for screening when invited. And we interviewed 20 younger women, so women aged less than 50, and 28 older women, so women aged greater to or equal to 50. And we found some really interesting findings in terms of the influences of screening participation and differences between older and younger women. And we found that many older women revealed negative body attitudes. And they had negative attitudes towards screening, and they reported age-related barriers such as embarrassment due to their aging body, vaginal discomfort, and considering screening irrelevant because of their age or because of their lack of sexual activity or having finished having their children. In contrast, younger women identified practical barriers to screening participation, such as lack of childcare and inappropriate or limited appointment times. In our study that was conducted with Survivor and CervicalCheck, older women reported the positive influence health professionals, so GPs and practice nurses, who often took the opportunities afforded by routine appointments to encourage these women to attend for screening. So these older women were prompted by their GP or practice nurse to attend screening. In contrast, younger women were often encouraged to attend screening by family members or by their friends. We found that most older women and younger women who were under-screened or never screened said that they would use HPV self-sampling kits if they were available to them, if they were mailed to them in the post. So now I'm going to spend the rest of my part of the webinar talking about the Access Consensus Group, which is a group I became involved in a few months ago. And we recently published a document called Turning the Tide, which is recommendations to increase cervical screening among under-screened and never screened women in high-income countries. So I'll talk a little bit about the recommendations. Firstly, I'll talk about the main barriers or the challenges that we identify that women have to attending screening, and then I'll talk about the marginalised or under-screened groups and who are these women. So the Access Consensus Group is comprised of experts with a broad range of expertise and experience in women's health and cervical screening. And we work to review the latest available evidence that supports optimal cervical cancer screening strategies in high-income countries with organised cervical screening programs. So the Access Consensus Group was recently at the EU Parliament with an event hosted by an MEP, and this event aimed to foster dialogue between policymakers, patient representatives and healthcare professionals from across Europe on increasing cervical screening participation among women in order to save lives. So why was the Access Consensus Group formed? Well, we know that in high-income countries such as England, Ireland, the Netherlands, cervical cancer burden has been dramatically reduced because of the availability of cervical cancer screening and the HPV vaccine. However, cervical cancer still poses a largely preventable health burden in these countries. And we know that cervical cancer screening participation has been on the decline, worryingly, in some of these high-income countries, such as the Netherlands and the US. We also know that cervical cancer cases are often associated with women who are screened irregularly or are never screened. These are known as underscreened or non-responders. So the marginalised populations, such as low-income individuals, are typically at highest risk of cervical cancer due to lower participation in screening or who have never been screened. So now I'm going to talk a little bit about the main barriers to participation that we reviewed, and we found from the evidence that's published in our paper on turning the tide. So the first one that we reported on was the lack of awareness. So some women may not be aware of the importance of cervical cancer screening. We also found a lack of appropriate provision of education. So some women may not understand the purpose of cervical cancer screening and the benefits and limitations of it. In countries where cervical screening is not provided free of charge, cost was a barrier. So in the US, for example, due to lack of or insufficient healthcare coverage. Cultural or religious beliefs were also acts as a barrier to participation in some women. So modesty concerns and misconceptions with certain cultural or religious communities may discourage some women from participating. And also in some of these cultural or religious communities, the male partner or the husband has a huge influence on whether or not a woman may attend for screening. A lack of a healthcare professional recommendation is also seen as a barrier to participation. So if the patient is visiting for another health issue and they don't receive a recommendation from a healthcare professional. In terms of psychological barriers, we know that fear or anxiety is a huge barrier for some women, and it's mostly related to discomfort or fear of discomfort associated with the test, or embarrassment about exposing intimate areas of the body to a healthcare professional. Women's own personal circumstances act as barriers to participation. So women who live in the countryside may have a barrier to screening due to distance, lack of transport, or inconvenient clinic hours. Trust and communication issues are often a barrier to screening participation, and these circulate around concerns about the trustworthiness, gender, or competence of health professionals. Communication barriers, language differences, and perceived dismissiveness by healthcare professionals may also be an issue for some women. False sense of security in terms of women's health may be a barrier. So women may feel healthy, they do not have symptoms, and therefore they misbelieve that there is no need for them to attend for screening. We know that physical disability is a barrier for screening. So one of the barriers in terms of physical disability is lack of accessibility to a healthcare setting because of lack of wheelchair access. Problems getting onto the examination couch of the test and previous negative experiences of cervical screening also act as barriers for physically disabled women. So now I'm just going to talk a little bit about the underscreened or marginalised populations, which we've included in the Access Consensus Group document. And we've highlighted these underserved populations and some of the challenges that they face. So we know that women who live in rural or remote areas often face geographical barriers to accessing screening. Women from ethnic minorities or immigrant populations face language or cultural barriers. Women from lower socioeconomic groups that are often at the highest risk of cervical cancer development face barriers to accessing healthcare in general. Homeless women or transient women face many barriers to accessing healthcare, including attending for screening. Women with learning disabilities may misunderstand or have barriers to understanding the importance of screening and giving consent. And then, like I mentioned earlier in the previous slide, women with physical disabilities face a multiple of barriers. Women from certain faith groups face language, cultural, or personal belief barriers to attending screening. We know that women who have experienced sexual violence have a fear or anxiety due to their prior experience of trauma. Working mothers with small children and single mothers often face practical barriers that I mentioned earlier. Obese women face many barriers to cervical screening, and these include things like getting up onto the examination couch and having fear or discomfort, while undergoing the test itself. Menopausal or postmenopausal women face barriers such as pain, discomfort, and perceptions of irrelevance, like I talked about earlier, that we identified in the Survivor study. Immigrant women fleeing a conflict face barriers in terms of inaccessibility to screening service because of the conflict they are fleeing. We know that commercial sex workers have prior experience of barriers to healthcare access, such as poor treatment and language barriers. And women living with HIV have exposure to stigma and discrimination associated with their HIV status. Members of the LGBTQ community, transgender women and non-binary people who still have a cervix. These are people that are often forgotten by the system as they are not registered for women, so it's assumed that there's no need for screening there, and they face a multiple of psychological barriers and homophobic reactions. So within the Access Consensus Group paper that I was talking about earlier, we included a series of case studies from different countries across Europe of, I suppose, good practice initiatives that different settings are adopting to try and increase cervical screening participation. And I've just highlighted one here from one case study from the UK. And it was a study that was run in an area of London that found that text message reminder invitations from the GP practice can help increase the number of women taking up cervical screening. So within that study, text message reminders were implemented across London boroughs between 2018 and 2019, and they found that the attendance for screening increased by 4.8% over the 6 months that the study was run. So the Access Consensus Group made 6 key recommendations in our document that I highlighted earlier. And these were to develop cervical cancer national elimination plans with goals for elimination by a predefined date, including national screening programme participation targets at the population level. And these would vary by different country. The second was to implement a targeted and culturally relevant information and awareness raising initiatives, particularly focused on underscreened or never screened women. The third one was to increase the accessibility of cervical cancer screening. And the fourth one was to support healthcare professionals to increase cervical cancer screening. Now, I've highlighted these three key recommendations as I feel they're the most relevant for this audience. The fifth recommendation was to encourage and support the creation of national cervical cancer patient advocacy groups. And the sixth one was to ensure that healthcare insurance appropriately covers screening in all high-income countries where screening is not free of charge. So thanks for listening to me, and I'm going to hand you over to Lynn now for the rest of the webinar.
So a big thank you to Marie there for kicking off the webinar today. I'm going to move on and look at what we know in terms of the evidence of increasing participation. What does the evidence tell us that primary care can do to increase participation? So the first thing that we would encourage you to do is use audit to help you look at who may not be attending for cervical screening. And when you look at the audit results and see potential communities or populations, that might give you some examples of why they might not be attending. It might be able to highlight the barriers that these people have to cervical screening, such as access problems that Marie talked about that's in the evidence, looking at childcare literacy, language barriers, cultural beliefs. Is there, populations or communities who have disabilities? Or what are the, I suppose, factors that are common across different communities that you might be able to work with those communities to remove those barriers? I think you need to be looking at things that are practical supports to these people, to removing those barriers and to increasing participation within your own practice. Another thing that the evidence tells us is that when primary care endorses screening, you can increase participation in cervical screening. Mairead showed the example of the good practice example from the UK that was shown in the Access paper. So by endorsing screening, what we mean by that is you reiterate what CervicalCheck has said to the woman. So you endorse screening and you remind the woman that it is a good idea to take up screening and to participate in some way. And you also let them know that if they have queries or concerns or they need more information, that they can talk to you. So we would ask you to do things like reminder texts, possibly letters, phone calls, looking at your audit results to who may be underscreened or never screened. The evidence also tells us that if you tailor that information, that you can increase participation. So little tips in the text reminder, for instance, could be the surgery opening times. If you're running a longer surgery day or drop-in clinic or an evening clinic or a Saturday clinic, you would put that into the text. You can reassure them that the sample taker will be female. And you might want to offer the opportunity to have a free conversation about any screening concerns that the person may have. I suppose it's important to remember that these people may have had previous negative experiences or they may have never been screened at all. So little tips for what you can put in your endorsement, if it is by text, by letter, or by phone call. So if somebody does request a pre-appointment check-in, and I suppose if we would encourage these if time allows, they might be looking for, letting you know the reasonable accommodations that they may need. So by reasonable accommodations, we mean they may be talking about their barriers and what would help them in terms of solutions to those barriers. They may be asking just questions about, what is screening and why should they participate. And I suppose really looking at the unique barriers that there are there for them for their own participation. I suppose what we do know from looking at barriers is that there are commonalities across barriers, but some communities have very specific, unique barriers that they would need help with, such as, people with autism or people with sexual, trauma in their past, things like that. So the evidence again suggests that if you use every opportunity to reinforce and endorse screening and to offer those check-ins on screening status, like checking eligibility at every consultation that you have with a woman or a person with a cervix, that you can increase participation in cervical screening. One of the studies that we looked at when we were reviewing the evidence for this webinar is the study at the bottom, and that looked at non-attenders for cervical screening in a number of East London practices. And it did show that those people did attend their GP surgery in the prior year. So it's not that these people aren't presenting. So we have to take every opportunity that if they are presenting, that we can do that little bit of education, that we can offer an appointment, offer that reassurance, ask have they any questions, and possibly take the test at the time or schedule an appointment for the test. That is shown to be very, very useful to people who are non-attenders or have never been screened at all. You might want to think about doing your own campaign locally. So based on the results of your audit, you might be able to show who is under-screened or never screened from your own database. And they might be the target audience that you want to communicate with. We've shown you that endorsement absolutely works, and you have some idea of what to put into those texts or reminder letters or phone calls that you're going to make in terms of your own campaign. Again, it could be advertising that you're doing a local drop-in clinic, that you've got female sample takers, that you've increased your clinic hours, and that you're putting in those little reminders to people. Postcards can work as well. Telephoning directly can work. Text reminders are a great way, or reminder letters. In terms of accessibility, it does show in the evidence that having longer and wider screening availability can support participation for women and people with the cervix. And that would include all of the additional hours that clinics run. So that's evening clinics, Saturdays, mornings, lunchtimes. A couple of other things to consider might be having buddy systems where people can come together in twos. You might want to consider childcare needs of people. And we absolutely can see from the evidence that running drop-in clinics does work. We have shown in a previous webinar a case study from the UK where a drop-in clinic did increase participation in under-screened and never screened people. So in terms of the CervicalCheck supports that we have available to you to do your own little local campaigns or to try something that might be a little bit different for you, you can look at the LGBT quick reference guide we have. We have some new animation videos that we're going to share with you today. We have information in translated languages, such as our videos and our cervical screening form. We have an equity tool that you can use that can show you all the different resources that we have in the one place. There is an access officer for CervicalCheck, and she can support anybody with a disability. There is the team that I work on, which are the health promotion team, and they can help you link in locally with anybody that you might be trying to target with your own local campaign. You might want to look at, different national campaigns. So things like European Cervical Cancer Prevention Week, which happens in January, or HPV Awareness Day in March. They can be a good idea to piggyback on the back of. You can also look at the STU clinical trainers as a resource for yourself. And also not to forget that we have a CervicalCheck LGBT point of contact. Today, we're delighted to share with you that we have new CervicalCheck information resources. These are accessible information resources. We have resources in plain English, easy to read. We have videos and we have photo stories for you. So the link at the bottom of this slide shows you where you will be able to access them, and we're going to pop them into the chat there as well. So I'm just going to give you an idea of what these look like. So here on the first one on the left, you'll have a guidance on supporting women with disabilities to use the cervical screening program. So this is just a resource that if you're working in the community with somebody who has language challenges, that you know what we've created for you. Okay, so that's not for cervical screening program staff. That is for people in the community working with women and others who may have information needs. So we've created easy to read information, which uses pictures, and it shows the patient journey using pictures. Our plain English versions then have no pictures, but they're for people who like to have the content without pictures, but in a very simple and easy to read kind of format. You'll see here on the left, we have a photo story. So that is following a lady on her journey, and it's following the same lady on her journey by using what's called a photo story. So it tells her journey as she goes through having her HPV cervical screening test. And then we move on and we have the same resources for colposcopy. So for colposcopy, we have plain English, we have an additional photo story, and we have a plain English photo story. So we're delighted to say that they are available now. You'll be able to get them on our website, and we will be communicating this out to people who may have language challenges. So that can be people who have unmet literacy needs. It can be women with disabilities, or it may be people whose first language is not English. But equally, it can be anybody who likes to have information in a picture format and who really needs support in visualizing what happens when you come in for a cervical screen or for a colposcopy. So again, you'll see these are some of the internal pages, and it breaks down the information in a step-by-step format in very simple user-friendly language. So all the language that you see that we've used here has been tested with the communities that we're targeting. So I'm going to show you a little cervical screening short video that we've just created. This is a little animation video. It's about 2 minutes long, and it might be something that could be a resource for you to send to women to show them what happens when they are coming for cervical screening. This is really brilliant for someone who is challenged in thinking about what happens when they come in and what the steps are. So we're going to show you this video and then we'll pop back to you to finish with the case study.
CervicalCheck. CervicalCheck aims to prevent cervical cancer or to find it at an early stage when it can be easier to treat. CervicalCheck invites women and people with a cervix for cervical screening. You are invited every 3 years between the ages of 25 and 29, and every 5 years between the ages of 30 and 65. When your screening test is due, you make your own appointment with a registered GP or general practice nurse. This does not have to be your own GP. Cervical screening involves taking some cells from the neck of the womb, your cervix. A nurse or doctor will place a medical instrument called a speculum inside your vagina to hold it open. Then, a soft brush is placed inside the vagina to take cells from your cervix. The test takes about 5 minutes. Some people might find this uncomfortable. You can ask the nurse or doctor to stop at any time. Your sample is sent to a laboratory and tested for the human papillomavirus, HPV. HPV causes most cervical cancers. Most people will receive a normal result, HPV not found. Some people will have HPV, but the HPV is not causing changes to the cells of the cervix. You'll be invited for another screening test in 12 months and tested for HPV. If the HPV is found again, or if HPV is causing changes to the cells in your cervix, you will be asked to go for another test called a colposcopy. A colposcopy takes a closer look at your cervix. This will be explained to you in more detail. Cervical screening can improve people's health. It aims to prevent cervical cancer or find it at an early stage when it can be easier to treat.
So that is a little video that we have created. It's actually for training purposes, but we do feel that it might have a role as a link to show people who are under-screened or never screened what we're inviting them for, and do a little bit of that education for them. So hopefully you find that useful.
CervicalCheck. CervicalCheck.
So just to finish up, we have a case study that has we've become aware of recently, and this was a lovely case study. I was talking to a community worker in West Cork, and he talked about the relationship that he had developed with a sample taker with a group of Ukrainian women who've been living in the community for a number of months, and a local partnership project. So the group of Ukrainian women had gotten together, and they had spoken to the community worker and the local partnership, and they had done some translated work with them using our resources and our materials. They weren't able to access cervical screening in the community they were living in, so they worked together to identify a different sample taker who could accept the group of women and who could put some time together to do a little morning clinic for them. They were able to organize their own transport and their own translation, and they were able to get screened. And I just thought it was a really nice example of how not only the practice manager, but the sample taker and the community worker, the local partnership project, and the Ukrainian women came together to identify their own barriers to cervical screening, but also their own solutions. And I suppose this is the work that we're encouraging to happen all over the country. When we talk to our colleagues in health promotion and in the community health field, we're saying to them that these are the things that really matter, and that small changes can really support participation. So for me in this one, it would really be the transport, the prep work that was done before the women identified that they would like to come for screening. So all of that kind of prep work that was done in the community, the provision of translation support on the day of the appointments, the provision of transport, and the ongoing communication with the community worker and the practice manager and the sample taker. I just thought it was a super example of what can be achieved when people work together in partnership, when a group are identified as under-screened, barriers identified, and then solutions are worked up together. And hopefully we can see more of these examples popping up around the country. And we would love to hear from anybody who's working on any little community initiatives like this. It's brilliant to hear that they're going on. And that's everything from me. So thank you for listening, and happy to take any questions.
Thank you, Lynn. I'm going to take in Sarah now for a wee couple of minutes of questions and answers. Sarah, I'm sure most of you know her by now. She's our primary care clinical advisor, and she's a regular on our webinar slots. And we have a couple of questions there, Sarah, and I'm sure that you and Lynn have got an awful lot to talk about as well. But just I have typed into the Q&A that we'd answer this question live. And the reason I wanted to ask it live is because it's one of the most frequently asked questions that we get as a training group when we're going out talking to the nurses, the doctors, and the other sample takers out and about. And the question is, should we be taking screening tests on somebody that would consider themselves a virgin? So I'll let you answer that, Sarah.
Thanks very much, Louise, and thanks again, Lynn. Fantastic presentation, and we'll certainly get more into conversations about equity and how we can support everybody to come and avail of screening if that is what they choose to do. But it is a relevant question in terms of our own perception of who might be at risk. So who are the people that we might be encouraging to come to attend for cervical screening? So anybody who's ever had any type of sexual activity at all at any point in their life is at risk of picking up HPV infection. As we know, HPV is the most significant risk factor for the development of squamous cell carcinoma of the cervix, which is the type of cancer that we are best able to screen for. And that's why we do primary HPV screening. So anybody who's had any skin-to-skin contact of the genital area, or any contact in terms of sex toys, or anything at all like that. So our kind of concepts around the idea of heterosexual sex, so what's often termed as penis and vagina sex, to be very specific about it. And that is, I suppose, what gives us these ideas about whether a person might be what's termed a virgin or not, or might have been in the past. That terminology might have been used. But what we know is that people have all sorts of sex in all sorts of different ways with all sorts of people. And again, this is very important for our LGBT plus community, that this is not about heterosexual sex. This is just about your risk of picking up HPV in any kind of sexual encounter that involves genitals. So it is important, if somebody says to you, well, I am a virgin, that they might use that expression. It's really important that you would talk to them, you know, well, what we're talking about here is any kind of contact of the genital area between two people. And sometimes you might find that people will say, oh, well, actually, I didn't realize it meant that. And then they'd realize that they're at risk. The other thing that we need to remember is that sometimes we make assumptions about certain parts of society, or we might have beliefs that, for example, maybe somebody with an intellectual disability or somebody who's living in a community care setting might never have been sexually active. We might even find ourselves not even asking them, or not asking their carers. And that, I suppose, is part of the difficulty that we find in terms of people being under-screened because of some of the assumptions that perhaps clinicians or caretakers might have about them. And unfortunately, as we know, some people will have had sexual contact against their will, you know, as a child or as a younger person, and may not be comfortable discussing this at all, but will have, unfortunately, then be at risk of HPV infection. So I apologize, that's a rather long-winded answer to the question which came in, which was basically the use of sex toys absolutely is a risk for potentially transmitting HPV between people, and that person should be offered screening. I suppose, Lynn, just to get back again to what we're talking about in terms of equity, and it is so important for us to remember that our screening coverage in Ireland is pretty good. So our annual report, our report since the beginning of the HPV screening programme in March 2020 was released recently, and that showed us that on average we have a coverage of around about 73% in the country. But that means that 1 in 4 people aren't attending for cervical screening. What we do know is that of the people who are diagnosed with cervical cancer, they are much less likely to have attended for any screening at all, and often we will find that they never attended for screening. So of the people who are diagnosed with cervical cancer, around 40% of them have never been screened, never attended for a screening screening test. And this highlights the importance of really targeting that 1 in 4, that 25% of people who, for whatever and multiple reasons, have not found themselves being in a position to attend for screening. And I guess, Lynn, that's what we're really trying to address here, is to really look at those communities that we know from research and from Mairead and Survivor's research and plenty of other research, that these are the underserved communities. And you've spoken about all those lovely ways that we can try and target them. And we have the link in the chat there for all of those new resources, which again, as you said, you know, they were kind of designed, I suppose, for people who might have difficulties around understanding with language or with reading, but they might be really useful for anybody who might need a little bit of extra support. And the video, as you mentioned, so the 2-minute video, that's something that could really easily be sent in an SMS message. And even when you were talking about, you know, the idea of audit, and sometimes that can be a little bit off-putting for people, it sounds like a big job. But we'll say, for example, in Socrates software, we know that it's very easy to run a report that just shows you how many people in the practice have never been screened. So just as simple as that, somebody who's never attended for a cervical screening test. And then you can, it's quite easy to set up a bulk SMS message to all of those people that pop up on that report. And like that, maybe a link to the video might be an idea within that. So that might be an idea for people. You've only about 7 days left before you're due to get your audit in for 2024 with the ICGP for this year, so that might be stretching it, but certainly to think about that in advance of next year. So I'll stop talking now because I've been talking too much, and I'm going to take a look at the questions. So I'm just having a look there at the first question that we have in relation to the what labs the tests are sent to. So 90% of the tests at the moment are sent to Crest Laboratories in the US, and that's where they've been going for the last number of years. So this is a quality assured laboratory based in the United States, and has been meeting all of the quality assurance markers that have been laid out and are very tight and very strict. So 90% of the samples are going to the US, and roughly around 10% at the moment are being tested in Ireland in the National Cervical Screening Laboratory. Lynn, was there any questions that came in there that you had any thoughts about, or anything that we hadn't covered there?
There's a question there.
So the screening test comes back positive, the patient needs to...
No.
Sorry, Louise, go ahead.
Sorry, I was just going to prompt you. There's a question there on management of fail-safe, but you were just about to start reading it. I overlapped with you. Apologies.
Yeah, so the person needs to attend a colposcopy but has moved to America. Do you wait on fail-safe from CervicalCheck, or how can you let CervicalCheck know patient is not in the country? So you have informed her that she has a colposcopy recommendation. She's going to America for a year, won't be home. She's going to speak to a GP in America about needing colposcopy. So I wish her the very best of fortune with that. But the fail-safe will come quickly to the practice if the referral isn't made. So as you know, what happens is that the referral form will come into you once the referral recommendation has been made. And on that referral form, that would be where you would usually be referring the person into the local colposcopy unit. A fail-safe form will automatically come in when that referral isn't received. But you can absolutely, make contact with the programme and let them know that this person will not be attending. The most important thing, I thought, from the point of view of follow-up with that person would be if she's planning on coming back to you, trying to make sure that she does connect back in again once she returns, as a, whether or not she's been able to access colposcopy in America, she really needs to come back and let you know. And I suppose just being sure that she is aware of the, decision that she's making around that. The question which follows up, which very often does in relation to this conversation around whether a hymen is intact or not. So what we know is that actually a hymen isn't a very useful indicator. It's if a person says that they've never had penetrative sex, that still doesn't mean that they do or they don't have a hymen. So a person might never have had penetrative sex and might not have any hymenal remnants or might not be intact, or they may have had penetrative sex and their hymen could be intact. So actually the presence or absence of a hymen isn't a very cut and dried situation. What we would always say in this situation is that it is worth examining the woman and having a look and see if a sample is going to be, if it's going to be easy to take a sample, if it's going to be not a problem. You're having this full conversation with the woman before you proceed. Sometimes people can get very concerned about this and they say, oh, it's, I've heard people say that this is assault, you know, that this is in some way against the person's wishes. You've had a conversation with this person. Let's use the example of a lesbian woman who's never had penetrative sex, but she's had plenty of sex and is at risk of HPV. And she has come asking for HPV screening. And between the two of you, you're shared decision making and you say, yes, let's go and have a look. In the same way, for any other reason, if the test was going to be difficult technically for any other anatomical reason, then you would say to her, okay, this is proving a little bit difficult. It might be, in some cases, you might need a colposcopy referral. But for most people, the first step is examining the woman with her consent, having a look and seeing if it's possible to do the test. I'm just going to make a point before I keep going. And sorry now, Lynn, I realise I'm totally hogging this, but feel free to jump in at any stage. Just a reminder to everybody that, and we mentioned this already in the presentation, a woman is, when you sign your CervicalCheck contract as a doctor, you agree to the fact that any woman can present to your surgery and have a cervical screening test done there. She does not have to be a patient of your practice. This is to ensure accessibility for everybody. This is to make sure that women, for example, if they have a small practice where they are very well known, or they might have you know, might slight concerns about maybe attending their own family GP or whatever reason that it might be, we want them to be able to access screening wherever they are. So your contract states that you are obliged to offer cervical screening to any woman who asks for it. She does not have to be a patient of your practice. We know that a lot of practices are full, and we know that a lot of administration staff, when they're answering the phone, you know, they've been kind of told, oh, well, we're not taking on new patients. And so they might have a kind of an instinctive reaction if somebody's saying, I'm not a patient here, but I'd like to have a screening test done, that they might end up refusing that person. We will always say that you could get the appointment only in the time that's allowed. I mean, a GP, you know, is entitled to say, well, the next available appointment is in 5 or 6 or 7 weeks' time. But you are obliged to offer that appointment. And what we know is that so far this year, in 2024, there's already been 18 women contacting CervicalCheck to say that they've had difficulty getting an appointment, so that they have tried to contact a GP and have been told that they can't get a test there. So that's 18 people already this year, compared with 25 people in the whole of 2023. So for whatever reason, and I'm sure it is GP practices being very, you know, full and lots of pressure on people's lists and on people's appointments. But it is very important that your admin staff would be made aware of, I suppose, maybe how to manage those situations when somebody is phoning up saying, I just want a screening test. We know that occasionally it might happen, a person might come for a screening test and say, oh, this is great, can I join as a patient of the practice? And again, you have to explain that quite clearly. That this doesn't mean that they'll necessarily be registered with the practice, but they should be in a position to be offered the screening test. The question says, you do not need to be on a register or have a letter to have a cervical screening test. You can make an appointment. This could waste appointment times if not you. Absolutely. So again, and this can be often a conversation to have with the admin or reception staff. For every person attending for a cervical screening test, we strongly recommend, highly recommend, that you check the register before the person comes for their appointment. I'm sure you all know, you go to cervicalcheck.ie and one of the first tabs that comes up is check the register. You pop in the person's date of birth and their PPS number, and that will tell you whether they're due or not. She can do that herself. You can send a text message with that link in it to say, you know, check that you're due. If you are due, oftentimes the admin staff of the practice will also check it as well. And certainly before she comes to attend, before the sample is taken, check the register. It changes. It changes at midnight. So the person's eligibility changes, and that comes up on our register. So if they're due that day, go ahead, take the test. And if you're in primary care, you will get paid. One woman stated that she'd never had any sexual contact or used a tampon. I declined doing a screening, but she got an invitation, but told her if she ever became sexually active to make an appointment. Again, Absolutely, same conversation that you're going through with the person, making sure that they fully understand their risks. A person who's never had any single type of sexual contact has extremely low risk of HPV-related cervical cancer. And so again, you can have that full informed conversation with the person and make sure that they fully understand. And like that, you can leave it with her. If she does become sexually active, she come back to you. Some people might still choose to have a screening test. Some people say, well, I'd still like to, they've got all the full information. They've fully been informed. Their risk may be very, very low. But, you know, she's eligible for a test if she's between 25 and 65. Okay, I might take a little pause there if that's all right. And I'm just wondering if there are any other questions there that anybody else wanted to come in on. Louise, I might even ask you just the posting of the smears. I might leave that one with you if that's okay.
Sorry, I missed what you said, but there is one there actually that Lynn probably would like to take. You know, what resources are available to the surgeries, you know, in the line of posters and literature. You know, for the immigrant ladies and for
Yeah, I see that one there, Louise. So my understanding is that we just have our cervical screening form in Ukrainian and our leaflet in Ukrainian and Russian. I think somebody's there asking for a poster in Ukrainian. Not that I know of, but if it was something that would be useful, you know, we might be able to look at a translated version of it. So normally we would look at translating materials when we know that there's enough, I suppose, critical mass and that we've enough requests in to do something like that. So it might be something we take as a note, Louise, and see if we get other asks in for the same thing.
Yeah, that's great. Thank you, Lynn.
And I've just got to pop into the chat the except I'm not able to put it into the chat. Send it to the host of panelists, and if you could send it on, Louise. It's just in relation to just finding those videos. So on the Translate Ireland website, and there's a number of videos in I can't remember, maybe it's 17 different languages, or possibly more. The one that I've put in the example is the Bengali one. So if you scroll down on that page, because there are a couple of different videos, some of them are COVID related, but the one in the middle is the one in relation to cervical screening. So basically it just explains what a cervical screening test is in all of these individual languages. So Translate Ireland, and as I say, you can just search for the particular language you're looking for. Again, something that you might be able to send in an SMS to a person in their own language and really gives them nice, clear information. And somebody saying they use the video in Ukrainian, so that might be from the from Translate Ireland. Somebody has asked a question in relation to women with a history of sexual trauma. So we do have an excellent webinar in relation to that. So I would strongly recommend, if you wanted to look back on our recorded webinars, I think it was probably early last year, maybe. And again, I'll see if I can get the link for that there for you. But that is really useful webinar in relation to dealing with people who have a history of any kind of trauma, but particularly sexual trauma. We have lots of other webinars in relation to very specific groups as well, and that might be worth having a look back. So we would have in relation to the LGBT community, in relation to people with intellectual disabilities. We have an excellent webinar from 3 nurses from COPE. So we do have quite a lot of resources on the webinars, screening for autistic people. So again, highly recommend that you have a look back through the resources that we have there, which have been really useful. Just the question in relation to posting the smears, is it satisfactory to leave Friday smears in the practice until Monday? Again, we had a little chart that we had done out in relation to trying to make sure that you're batching the smears together. So we do recommend that it's within 3 working days. So a smear done on Friday can wait until Monday. But ideally, what we would suggest is people doing smears Monday, Tuesday, Wednesday, get them off on Thursday morning, doing them Thursday afternoon, Friday morning, Friday afternoon. If you can get it into the post on Friday afternoon, that's probably optimal. But we do realise that sometimes people might be working late on a Friday. Have I missed any other ones? The woman is not registered yet, but eligible for screening. Can we perform the smear test on the same day when she's present in the surgery? Absolutely. So again, you're having a conversation with her. She's arrived in, you're chatting about other things. If you have the time, she's had enough time to maybe take in the information that you've given her, you feel comfortable, maybe she's had screening, done somewhere before, you check the register, and if she's not registered, but she is eligible, so she's between the age of 25 and 65, then by virtue of sending off the test, that will actually register her. So once you can have all her, and that's why it's so important to have all of her information right on the screening form. You want to make sure that you've got her right address, her correct address, her correct date of birth, all of those things. Her mother's maiden name can actually be a very useful indicator when we do end up with a number of multiple people with a number of multiple different names or the same name, which can happen. And you send that off, and then she becomes registered on the cervical screening register, and then she will be invited then from then on. She'll be maintained on the register. And there's another one that popped in relation to a patient left the country, comes back needing colposcopy. Obviously, I'll be contacting the patient. Will I send the referral to colposcopy if I know when she's coming back to Ireland? Yeah, you could absolutely do that. Yeah, get in contact with the local colposcopy and say, she has needs referral to colposcopy for whatever reason. Her previous test said that she needed a referral to colposcopy. You can give them the heads up and say that that's when she's due in. We'd be strongly encouraging, lots of intercollegiate chat with the local colposcopy unit. That's what they're there for. So getting familiar with your local colposcopy unit, giving them a call if you're not sure, sending in additional information about the patients. Again, like that, if somebody has additional needs, it's always great if you have a chance to chat with the colposcopy maybe before she gets there and just explain her particular circumstances. That's always going to be really useful, both for the patient and for the staff in colposcopy before she gets there. Okay. I'm rattling through all of that. Sorry, Lynn. Was there again anything that you wanted to
at a wonderful pace? At a wonderful pace, as always, Sarah. I don't. Oh, there's another question in as there just popped in. No, it's the same one. Sorry. Listen, as always, the 50-minute always flies by, and bearing in mind that people are generally on their lunch break during this, it just leaves me to thank most sincerely Lynn and Sarah for giving up their time yet again to deliver a really worthwhile webinar. Now, there's an awful lot of links in the chat today, so I've also put in the email for stu@screeningservice.ie. If there is anything that we didn't get in today, and if anybody wants any more answers to a question they have, feel free to put it to the stu@screeningservice.ie, and we'll endeavour to answer it in a timely fashion. The other links are still there, and as always, I give you the prompt. If you do take a few minutes to fill in the Smart Survey link today, because we're planning our autumn diary of learning events, and if you have anything that you would like covered that we haven't covered before, we're always delighted to get your suggestions and your feedback on the webinars that we do. Now there is a change in in 2 weeks' time. There's a change in our advertised webinar. We actually have Sarah with us again, and our clinical director Noreen is going to give us an update on the cervical screening report, and and how we're going to empower the sample takers to use the stats that we have to improve uptake of screening and improve your practice based on what we have audited and looked back on and reflected upon. So with that in mind, again, thank you for everybody that came in and joined us today. Time now for coffee before you start your very busy afternoon clinics, I'm sure. And a final thank you to the two girls for their excellent delivery. And of course, Mairead in her absence, thanks to Mairead for giving us a pre-recorded video, and it was very, very useful and full of information. Okay, so that just leaves to leave and get on with the rest of our day. Thank you, ladies.
Thanks so much.
Thank
Thanks,
you.
Lynn. Thanks, Louise.